Welcome to the EAU podcasts.
Welcome everyone to EAU podcast. My name is Pawel Rajwa. I am associate professor and urologist from Poland, and it's a great honor for me to talk today to Professor Gillessen Sommer on the present and future directions of metastatic prostate cancer treatment. Welcome, Professor.
Hello, Pawel. I'm Silke Gillessen. I'm a medical oncologist from Switzerland. So thank you very much for inviting me. It's really an honor to talk to you about metastatic prostate cancer, what is, of course, a very interesting topic.
Thank you very much. So my first question is, if you look at the last 10 to 15 years of trials in metastatic hormone-sensitive and castration-resistant prostate cancer, what do you think has driven the biggest survival gains? Is there like better drugs, better overall prostate cancer management, like earlier treatment intensification, better sequencing? How do you feel what led to all this survival gains in the last few years?
Yes, that's a very good question. I think really, for me, like the biggest step was the combination therapies in metastatic hormone-sensitive disease. And as you know, well, it has started with docetaxel, but nowadays, the combination that is most used, the most powerful, is the combination for most patients, ADT plus an RP. I think it's not that important which RP, but this doublet has shown a fantastic increase in overall survival for patients with metastatic disease, because that's what you're asking me, right? Like if you compare this is more than 1 year of survival gained. And that's important also, an improved quality of life, because a lot of patients with prostate cancer are very reasonable. They say, okay, yes, it's one thing to live longer, but I also want to have a good quality of life. So in this combination, both is improved, right? So the quality of life and the overall survival. And that's more than 1 year. And that's really something that you don't see that much in oncology. This is a big gain, right? At least in my impression, a lot of it is driven by that. Of course, we have the radioligands, we have new mechanisms, we have new drugs also in later stages. But I think one of the big really improvements was giving the combination from the beginning. And as you know, unfortunately, not all men are receiving it. We know from real life data that still in a lot of countries, not only there's data from the US, there's data from Europe, still quite a big portion of patients don't get the doublet. In some patients, that may be also right because they are frail, because they are old. But I think there is also a part of patients who just don't get it because we don't do enough education.
Thank you very much. And now I'll proceed to the second question. Triplet therapy has rapidly become standard for many men with mHSPC. In your view, have we reached a point where this triplet therapy, where intensification is a default like treatment, or now we are I would say it's still over treatment for most of the men, or how should we select optimal patients for triplet therapy and for doublet therapy in mHSPC setting?
Yeah, that's a very good question, because we actually don't know exactly how to choose the patient. So first of all, I think you speak about triplet systemic therapy, and the triplet that we're using now, most of course is the treatment with ADT, RP. I think this is always the base, and adding docetaxel to it. We have never asked that question, if really the addition of docetaxel gives a benefit. We have asked the question, gives the addition of RP a benefit for the doublet with docetaxel, but we don't have really big phase 3 randomized trials asking the other question, if adding docetaxel to the RP ADT doublet, what is now the standard of care, is really giving you an improvement. I personally, yes, I'm discussing it with fit patients, but already a lot of patients, you would consider maybe not fit for docetaxel. Or the patients tell I don't want I don't want chemotherapy. Sometimes the patient is very clear about that as well. So it's clearly not, the triplet is not for everyone. Best data we have about the patients with de novo disease, high volume, even if we can discuss if that's the right definition and so on. But I guess, these are the patients with the worst prognosis. And I guess that's something to discuss with them, the triplet. I'm never, ever considering a triplet for metachronous, low-volume patients because we have data that their docetaxel added to ADT doesn't give any benefit. So I don't think it's going to give a benefit when added to ADT-RP. With the other patients, I'm discussing it if they're fit enough. But, I think not everyone is getting it for sure. But maybe it's a bit underused because, a lot of people are very afraid of docetaxel. So I think you shouldn't have this chemophobia, right? Because that's also something important because in some patients, docetaxel really helps. And, you can always stop it if a patient doesn't tolerate it well. So the patient can decide if he wants to continue for the 6 cycles, yes or no. And now, of course, we are starting to have new triplets, as you know, right? So we had data with Amplitude, with the PARP inhibitors. In this trial, you could even get a quadruplet with the PARP inhibitor plus the docetaxel, right? So it gets more and more complex. So in my opinion, of course, it's not approved yet in Europe, but FDA has approved niraparib for the patients with BRCA2 mutations very recently. So I think, there was really a benefit in our PFS. The hazard ratio was 0.51 something, I guess. This is really strong. So I personally, if I would have the option, if it would be approved, discuss with the patients to add niraparib if they have a BRCA mutation in the tumor is a very sensitive thing to do. And then, there were the new data with the ACT inhibitors, with the lutetium PSMA. For the moment, I think the RPFS benefits are not as high as we wanted. We haven't seen OS data. The data is not mature, so the books are not closed for the moment, a bit early, but we will have other triplets very soon. Something that, was quite interesting is there was a very good paper from Emily Grist from Gert Artas lab. I'm involved, so I'm a bit biased, but I think it was really interesting to see that maybe patients with PTEN loss measured by transcriptomics and patients with a high-risk decipher are the patients who are more responding to the addition of docetaxel. I think this is quite interesting data. It came from the study where there was not an RP involved, so we have to see what happens, and it has to be formally validated in reality. But I think that data is quite interesting, unfortunately, at least in Switzerland, but I think in all Europe, we don't have easy access to decipher yet.
Yeah, so thank you very much. And once you start treatment, do you think also about the intensification? For example, I don't know, you look at PSA response, imaging response, like for example, you start with RP or triplet and there is like exceptional PSA response. Would you consider the intensification of the course, or how do you feel it?
Yeah, this topic is very close to my heart. So yes, we have an ELTC study. It's called the De-Escalate. I really invite everyone to be a part of it. It's a very pragmatic study, and is exactly the patients that you say, patients who reach a PSA nadir of less than 0.2 after 6 to 12 months of doublet RP-ADT therapy, or also after triplet with docetaxel, and we will randomize to do intermittent therapy versus continuous therapy. So we evaluate this question of intermittent therapy in the metastatic setting. And I think, because a lot of patients really would be happy, I think, to have these therapy breaks. They ask me a lot. We don't know if it's as good, the SWOC study with ADT alone, but that was really an old study. The PSA was very less sensitive in that moment, They used 4 as a cutoff, was not non-inferior, But I think we have to revisit this question. And the good news is we have already included 94 patients, so the accrual goes really well. So thank you to all the investigators, Denmark, I think France, they are really very active. The first patient in Ireland. So I think, this trial is hopefully going to recruit fast, and then we will have an answer to this question. But I totally agree with you. I think we have some patients that would profit from treatment breaks and the de-escalation.
Thank you very much. I also agree, and I'm looking forward to the results of the trial. With PSMA-PET redefining metastatic disease, do you think we should already be adapting our systemic treatment strategies based on molecular imaging, or we should make our decisions based on conventional imaging? How do you do it? And also in your clinical practice, you look more at the PSMA-PET results, or you focus on conventional imaging?
Well, that's a very good question. So as you know, all the studies that we have for treatment were done with conventional imaging, right? But we do more and more PSMA-PET in Switzerland, but I think all over the world right now. And here is a bit, it's not always easy, right? But you can't ignore the PSMA-PET, I think, And I guess the most important actually findings are the patients that are conventional imaging M0, and then you see 1 or 2 bone mets, right? So oligometastatic disease. And of course, you can't ignore that. I try to always have a confirmation, because also PSMA-PET, also if it's our best imaging in the moment, is not perfect, right? So I think the danger is, especially with the fluoride PSMA-PET, that you have artifacts in the bones, especially in the ribs, and then you take away a curative option from a patient. That shouldn't happen. So you have to be very careful. So we confirm either with conventional imaging or even this biopsy. If you really are not absolutely sure that this is a single bone met, I think you need to have confirmation before you say, okay, no, we don't do any longer prostatectomy or like radical radiotherapy, in my opinion.
Thank you very much. And now with with all the PARP inhibitors, PSMA, radioligand therapy, ARPs, how do you feel? How close we are to choosing therapies based on tumor biology, on genetics, rather than clinical phenotype, not only high volume, low volume, but based on, I would say, through biology and genetics?
Yeah, I think, to be honest, we are very close, and that's nice. So we have the capabilities, but one of the problems is not everyone has access. So I don't know how it is in Poland, but I know from my friends in Italy, in Spain, it's not so easy to get an NGS. We are quite fortunate in Switzerland that we can do one. And I hope, because it's also getting less and less expensive. So I do hope really that more and more doctors have access to these new molecular tests. The PSMA is also a good biomarker in a way, right? Like doing a PSMA-PET, but also there, as before I said, okay, we have access, but not everyone has access also to PSMA-PETs. So it's not, we are a bit fortunate in our countries, but there's still a lot of countries where you don't have access neither to NGS or to PSMA-PET. But I think we are making progress in the right direction. I think what now is a bit missing is that we do really good trials. I think that PSMA addition, personally, the idea was a very good one, but maybe we haven't selected the patients optimally, let's say it like that. The same thing, if you look at amplitude, the patients really profiting from the PARP inhibitors are the patients with BRCA mutations. If you look at the HRR without the BRCA mutations, the hazard ratio is for RPFS is 0.81. This is not impressive, right? So we have to learn much more, because there is the BRCA, I think for me, is quite clear. The other HRR, less frequent HRR mutations, even BRCA1, it's a bit more difficult to understand how much benefit the patients have. So we have to learn And we shouldn't put everything in one box, right? I think we have learned that some HRR mutations are more sensitive, like also BAL-B2, and some others are much less. So I think here we have to be very much more granular and make also the studies more granular.
How about PTEN deficiency? How do you feel it? Now we have some treatments, and when the patient has PTEN deficiency, do you treat or manage the patient differently currently, or you feel that at the present state it should not strongly influence our decision making?
So what was very interesting to see in Capitello is that these patients with, that was immune histochemistry, and we know from the mCRPC state that probably NGS would be more sensitive. But of course, again, here the problem with access, right? Not everyone has access. So they did the trial with using immune histochemistry. And you have seen the data, right? So many patients had to be excluded because they didn't have a loss in more of 90% of the cells. So, that will be a small subgroup. Already in Capitello was a small subgroup. And even in that subgroup, you saw that the patients who have 100%, let's say, deficiency, as they called it, by immune histochemistry, have a much better hazard ratio for RPFS than the one with 90%. So in that sense, again, selection is key. And how you measure it, because as you know well, it's not easy to measure loss of function. So we're measuring something in the cells now by immune histochemistry, but we don't know what happens really in the functional assays because we don't use them. So in that sense, I think again, we have to learn how to select well these patients, but I'm quite confident that if we would select the patients well, we would find some patients who really profit from these treatments that are not untoxic. So in that sense, it's important that we find out. And there, in that trial, Capitello, docetaxel was not allowed. So we should also understand if docetaxel or the ACT inhibitor is better, in these specific patients with the PTEN loss, because we have emetic data that also suggests that the patients with PTEN loss respond also better to docetaxel. And I think that's quite interesting. So we will have to learn a lot. And then we also have to teach our peers, right? Because I don't know how you are very young, so maybe you learned already in medical school about all that, but we make so much progress. Then we have to learn how to interpret a report from a liquid biopsy, from an NGS, from all of these things. So I guess we have a lot of teaching to do for all of us, right? Because we didn't learn that in medical school.
Okay, but I have also one question. So when do you suggest to perform NGS? At what prostate cancer stage? At mHSPC, when it's high risk, or when it's metastatic castration-resistant disease, or at diagnosis? How do you feel when we should do it? In 2026, I would say, not by then.
Yeah, so I think this is really depending on your country. I would do it when it does influence your choice of treatment. So in countries like now the States, where you can give a PARP inhibitor in metastatic hormone-sensitive disease when you find a BRCA mutation, BRCA2 mutation, of course, then it makes sense to do it then. Ideally, we would do it in that moment because we would also learn, because as we said, patients with BRCA mutations and patients with PTEN deficiency have a worse prognosis. So these patients maybe also you want to do more imaging or more monitoring than in other patients. It's not only about the treatment, right? Because we know these patients have a worse prognosis with the standard treatment, ADT plus ARPI. So maybe we should do a bit more monitoring in these patients. So, the whole management could be changing. So I personally, if I could choose, I would do it in metastatic hormone-sensitive disease. And then the other thing, of course, is, what is important. Again, not everyone has access. And then I think it's important you do it when, you can give maybe an mCRPC first line, a PARP inhibitor, but not in metastatic hormone-sensitive disease. Then do it then, right? But in the end, if you have an ideal word, I would do it already in hormone sensitive. But I wanted to say, don't forget germline, also genetic counseling and germline testing. I guess we are doing it for all metastatic patients in the beginning of metastasis, but also in high-risk localized or patients who have cribriform components. But again, we have access to this, but that can help as well, of course, if you don't have access to somatic testing.
Okay, imagine you had this conversation, in in 10 years, how do you feel which parts of today's metastatic prostate cancer management and treatment will be outdated? And on the other hand, how do you feel like the treatment of metastatic prostate cancer will look in 2036?
That's not easy to say. I hope for our patients that ADT will be gone, because ADT is just not something that patients like. So I really hope for our patients. I don't know if it will be possible, but I think for our patients, I would really wish we could find also some treatment schedules without ADT. I think that would be a really good step forward, at least for, again, some patients. So that I think would be fantastic. I think what we also know that in 10 years, we will have a big surge of patients with prostate cancer, of the cases. We have done a Lancet commission together with James Endo and with Nick James and Felix Feng. We have seen that there is a huge increase in cases for in 10, 20 years. And most of them will be in countries with limited resources, in Africa, in parts of Asia. And I think there, we really need completely new ideas. And I see in your compass AI, you are an AI specialist, right? So I hope we can use AI well, specifically also in these countries, to help with diagnosis, with help a lot of these patients that in the moment are probably found much too late. In general, I think it would be so important we concentrate on early detection of prostate cancer so we can really treat early. And it would be my dream to see less patients with metastatic prostate cancer. So we have to, I think, also invest our energy and time and money for helping with early detection. And I hope on young urologists like you to find new methods, but also patients with less access have, can do that maybe by a smartphone at home or something. I think it would be fantastic if we would find ways there.
Actually, I think because now in Poland, PSMA-PET became reimbursed for primary staging, I've got a feeling now we will have probably a surge and we'll have more and more metastatic cases, but of course there's some sort of state migration. But at the end, I'm really thankful for the interview. I think it was for me, it was great honor to talk to you, and I'm looking forward to see you at APCCC Advanced Prostate Cancer Consensus Conference.
Yeah, thank you. Oh, this is nice you mentioned it. So yeah, we will discuss a lot of these things also at APCCC, more like the daily management with the data we have now. So we're not looking into like you did up in 36 already, but we really, what are we doing with the patients right now? And I think this is really becoming more and more complex because we have more and more new drugs, new tests, and I think it's important to discuss together what is the best thing for the individual patient.
Thank you very much again, and see you in Switzerland. Thank you very much.
Thank you for listening to this episode of EAU Podcast. To keep up to date with prostate cancer developments, visit our educational platform, UROONCO Prostate Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.